remarks.
No.
Oh, this is for Dr. Adoo or Dr. Kyle, either one or both. Do you see any correlation, since it's a disease of the older person? I'm not saying elderly, but particularly in women, do you see a correlation in women with severe osteoporosis and multiple myeloma?
I think yes, in the sense that both diseases are diseases of older individuals, but one of the things that's not often recognized is that men also get osteoporosis sometimes. And it's last night, just before I came in, I was looking at the NCCN guidelines. NCCN is a collaboration of some of the major cancer centers in the country, and they put together consensus guidelines about treatment of multiple myeloma. And I looked at the first, what they indicate as the first line treatment for multiple myeloma, and I counted them out. There were 8 or 9. Every single one of them included dexamethasone. As most people know, dexamethasone also, or any steroids, contribute to the risk of bone disease in the form of osteoporosis. So yes, there is a correlation between those diseases, both in the sense that patients with either one might have a risk of the other, but also the treatment of multiple myeloma. In treating multiple myeloma, we have to be very, very cognizant of what we are doing to the bones and how we can prevent bony disease.
I believe we have a question over here.
Let me just make one comment about age. When you talk about the older patient, an older person is always a decade older than you are.
Thank you.
I just found out that my my father has multiple myeloma, and he lives out of state North Carolina, and he is a more mature person than I should say then, okay? I'll give you that much respect. And when I'm learning a lot here at the conference, and I thank all of you for that, because now I have a better understanding. But my question is, he must have had a stem cell transplant, and he didn't let us know until November when we almost lost him. So in his recovery, he was able, and I'm not sure if this is what he had because he's very secretive in what he's telling the family. So my concern is, he said that he could not have this treatment again if he should get sick or have any kind of infection coming back again. So is what I'm hearing is that he may be able to have the same type of treatment again, or am I incorrect?
It's a very individualized decision that the patient makes with their physicians and caregivers. So what I was trying to present was a more average situation. There are indeed individuals who will be deemed to be unsuitable for even a first transplant, or having had a first one might not be good candidates for a second one, either because of side effects or because it might be felt not likely to benefit them because they have other alternatives or do not need it. So yes, there are some patients who will take a first transplant and then be advised against trying to take a second one.
Since this is affecting so many older people, how is Medicare responding to picking up the cost of treatment?
One of those questions. Nobody wants to answer that.
The Medicare will support financially a transplant until, I think it's age 77. And that was due to a meeting that we had in Washington a number of years ago, both physicians and patients. And I'll never forget a fellow who jumped up, said, "I'm 84 years old and I've had 2 transplants, and look at me now." And he did look very, very good. But they will do that. The rest of it is pretty much on a on an individual basis, and I'm not an expert in this area, and I think that very, very few physicians are. It's a complex area of reimbursement that's very difficult to understand.
When we did transplants here at City of Hope, we probably had about 10% of patients with insurance turned away by their insurance company saying they wouldn't cover it, and sometimes you could overcome that by fighting it, sometimes you could not. Many insurances also did not want to cover a second transplant even if they cover the first one, because insurance decisions generally lag a little bit behind the proven treatments. And then there are still a large number of patients who do not have insurance. Even those insurances and Medicare and so on who do cover a transplant might only cover certain aspects of a transplant. So the biggest problem we had at that time with Medicare was they would only cover a transplant if it was an inpatient procedure. So sometimes you would have to be hospitalized even though you could otherwise have had the treatment as an outpatient. So there are insurance issues and there is room for advocacy and looking forward to getting better with that.
Thank you very much to the panel. We really appreciate you.